This is the Emergency Medical Minute, sponsored by Health One.
The Emergency Medical Minute and CarePoint hosted a panel with 10 speakers on a wide variety of topics. This is Dr. Dylan Luyten answering the question, does this patient have ACS?
Two seemingly unrelated topics. So the first one is I'd like to kind of instill some pearls about how to most effectively evaluate someone as to whether they're having an acute coronary syndrome. And I think it was Tad who requested this topic. It was an MRAP, a medical legal briefs from February of earlier in the year when they were looking at an ACS case. And podcaster was kind of going through the value of certain historical elements and things in the assessment, and it's a little distressing. And so I thought I would kind of tackle this in an organized manner. So let's consider two cases, and don't need to say anything about it right now, but as we go through the lecture, think about how you would approach these patients. So the first case is a 42-year-old otherwise healthy female who presents to the ED with 45 minutes of fairly typical crushing retrosternal chest pain. In the ER, the pain is completely resolved after a couple of nitro. Her EKG at that point is pretty unremarkable, and initial troponin is normal. Contrast that with a second patient, a 74-year-old male, history of prior MI, who comes in with several days of intermittent kind of burning retrosternal vague chest discomfort. His EKG shows signs of an old MI with Q waves inferiorly that were present on his prior EKG without any new changes. His initial troponin level is weakly positive. And so think in your mind sort of how you would approach these two different patients and how you would assess their probability of ACS. So if you're not familiar with it, JAMA has this series of articles called the Rational Clinical Exam that are really good. And this was I'm going to reference a paper, a meta-analysis of the assessment of chest pain from JAMA that's really very, very, very good. And really what we learned from that article is that there is no EKG historical or exam feature that is effective at ruling out ACS. In fact, if you look at each one of the things that we put a lot of stake in, like they were sweaty, or it radiated to their arm, or they were short of breath, or it was exertional, or by contrast, it was pleuritic, or it was reproducible, it turns out all of them perform very, very poorly in terms of their predictive value. So risk factors, moderately helpful. And so if you're not familiar with likelihood ratios, a positive likelihood ratio tells you the likelihood of the patient who tests positive having the disease as opposed to the patient who tests negative. So a positive likelihood ratio is the sensitivity of a test divided by 1 minus the specificity. And the reason likelihood ratios are a good way to express the probabilities associated with medical research is that it allows you to act as a multiplier against your pretest probability. So if you think the pretest probability probably doesn't have the disease, maybe 10% chance, right? Then a positive likelihood ratio of 2.7 increases that rate to 27%, if that makes sense. So, by the way, what is the prevalence of ACS in our ERs? Does anyone know? And remember, when I say ACS, we're not talking about STEMI, because when we see ACS, really what we're talking about is non-ST elevation coronary syndrome. So the prevalence is about 10%. When you look at I think it was something like 50 papers that were included in this meta-analysis, their disease prevalence was about 13%. So in other words, most people we see and evaluate for the disease don't have the disease.
13% of chest pain. Not 13% of all of our patients, right?
Correct. People you're considering ACS in, who you undergo a workup, whether it's an admission and a cath, or whether it's 3 troponins and 2 troponins in home, whatever it is. This patient population has ACS around 1 in 10. So it's a relatively less common outcome. So if you look at when you think about likelihood ratios and how to assess them, a positive likelihood ratio to be useful needs to be significantly higher than 2. And a likelihood ratio of 1 means it has obviously no change. And then a negative likelihood ratio, same proportions. Sometimes when you look at a a positive likelihood ratio of a thing that's not associated with a disease. So, for example, a pleuritic chest pain has a positive likelihood ratio of about, I think it's about 0.5, meaning if you have pleuritic chest pain, you can multiply your pretest probability by 0.5, essentially, if that makes sense. So to come back to having given that background, risk factor is not super helpful. It turns out that a history of an abnormal stress test and history of peripheral arterial disease are the only historical features they looked at that had a positive likelihood ratio significantly higher than 2. Specifically, physical exam is terrible. All aspects of the physical, which is not surprising. You really don't need much of a physical exam to evaluate chest pain most of the time. But hypotension is the only physical exam finding that they looked at. They look at RALs and S3s and murmurs and pulse pressure and all these things. It turns out hypotension is the only thing that has a significantly positive likelihood ratio. Yeah.
Positive likelihood ratio. What about the negative likelihood ratio of clearly reproducible positional? Is that
excellent? Reproducible with palpation, a positive likelihood ratio of 0.28. Useful. So
that's useful.
Useful. So you can cut it by a quarter.
That's far away. I couldn't see it.
Yeah. No. Absolutely. Good point. So that's my next point. When you look at what clinical features, so the things we think about, like it radiates to the left arm, my jaw hurts, I'm sweaty, it's in my back, I'm nauseated, it was exertional, all these things, essentially unhelpful. All have likelihood ratios around 1. So has a very, very poor predictive value for the ultimate diagnosis of ACS. Bilateral arm radiation, which many of you may have heard before, is the only really historical feature that's very convincingly, has a strong positive likelihood ratio. Best performing, better than all of these historical physical exam or EKG findings, are the risk scores. So this is actually helpful. This is good news for us. So if you look at the heart score, the old-fashioned TIMI score, or a newer score that we don't use, which is the Australia and New Zealand Cardiothoracic Society score. It has a very long name. If you have a high-risk heart score, so a heart score of 6 or greater, then that has a positive likelihood ratio of 13. So very, very powerful. A low-risk score, so the 0 to 3s, which are most of the folks we're typically evaluating in our low-risk chest pain pathway, has a negative likelihood ratio of 0.2. So the posterior probability or post-test probability associated with a low-risk heart score is actually very powerful and is better than any physical exam finding, EKG finding, et cetera, et cetera, et cetera. The most predictive EKG score, which unfortunately is not super helpful, is the presence of ST depression as a positive likelihood ratio of 5. So very strong. So if you have ST depressions on your EKG, that is a highly concerning finding. Yes?
We hear a lot about how women may present differently.
Yeah.
Yes.
That's
Any of this break down the likelihood ratios on symptoms for men versus women? That's
a great question. Not addressed in this paper, but that's a great question. So, if you look at the single most consistent complaint amongst females diagnosed with ACS, does anyone know what it is? It's fatigue. So the fatigue is the most universally present, more prevalent than chest pain itself. All right, so to summarize, based on these facts that we kind of described, a rational approach is that really when we are considering ACS, and we should consider it liberally in our patient population, we should establish a pretest probability, and we should use the heart score. We should emphasize the heart score over any specific physical exam or historical feature that we might otherwise anchor on. For example, it's pleuritic, I think we're okay here. Or it's reproducible, I'm not sure we need to worry. A more consistent evidence-based approach is to simply apply a heart score and act accordingly. So let's evaluate those two cases that I put together. So the case one was the relatively young, healthy female with a normal EKG, but very typical symptoms that were relieved with nitro. So As we described, typical symptoms have a positive likelihood ratio of 1.3, so don't help you. Relief with nitro, completely unhelpful, like positive likelihood ratio of 1.1, 1.2. Young, normal EKG, fairly predictive under the heart score. Negative troponin, she gets a score of 2. Her ACS rate is 2.6% based on the heart score literature. So this is a patient who is very unlikely to have ACS and should be likely discharged. Case 2, this is the older guy with more atypical symptoms, a history of an MI, an abnormal EKG, but nothing new, who has a mild troponinemia. So he has a heart score of 6 based on that assessment. His positive likelihood ratio is 2.4. So he's actually technically intermediate risk according to heart score. Greater than 6 would be high. And his posterior probability then of a baseline population, a baseline prevalence of the disease in this study of 13% gives him a posterior probability of over 26%. And this is a guy who almost, most likely does have ACS and should be hospitalized. Questions? Yeah, a bunch of questions.
In terms of people with early discharge, the heart score only works up a single troponin.
That's correct.
If she comes in within 2 hours, would you still 3-hour trope that person, even if her initial heart score is low?
Great question. So the decision about serial troponins is more based on guideline behavior. So our guidelines that we follow, whether it's ASAP or whether it's ACC, recommend serial troponins. But the evidence for the efficacy of serial troponins is actually very, very poor. If you look at the additional diagnostic yield of a second troponin, it's exceptionally poor. So when you look at folks who rule in, the vast majority are ruling in based on an initial abnormal troponin. I'm not advocating for not doing it, but it's important to realize we don't get much with our second troponins other than medical legal comfort and potentially protection and a sense of confidence based on our guideline adherence. Yeah, it's a good question. Other question over here?
So within the context of the heart score, I mean, you're not equal weighting to each individual measure, right?
Yeah.
So if you have ST depression with your EKG, it doesn't matter what the heart score is. Or if you have a trope of 5, it doesn't matter what the heart score is.
Yeah.
So there are certain things that might trump the heart score.
Yes. Yeah. Of course, a patient who anytime you apply a decision rule to a patient, what's implicit but not always stated is usually the statement, I don't think the patient has the disease and I'm applying an excess rule or I'm doing whatever my risk tool is. So in a patient where you think the disease is present, whether it's Gestalt or EKG findings or a troponin of 8 or whatever it is, it's sort of everything goes out the window. Yeah, good points.
It's a form of pretest probability, right? It's pre-score probability, but it's kind of like using a D-dimer. It's irrelevant if the patient's had a PEEP or whatever. You don't even need to run the test, but the pretest probability is high. So if their EKG shows ST depression, then our heart score is irrelevant because the pre-score probability is so high.
Yeah, I mean, it is important to say, like, ST depression is accounted for within the abnormal EKG, component of the heart score. I think you can still use the score, but you'd probably be foolhardy if you're...
You can't use it as a negative predictor at that point.
Correct.
It wouldn't lower, like, a pre-cap probability low enough for you to be comfortable with them all, right?
Exactly. So if you, to be specific, so a heart score of 4... which has a positive likelihood ratio of 0.79. So in other words, it actually still is decreasing your probability of the disease, just not by enough to make a difference, which is what you're saying. Or a heart score of 5 to 6, which is that intermediate risk, has a positive likelihood ratio of 2, so probably has value, but isn't as powerful as you might think. Like you think, oh my God, that guy definitely has ACS. And then it turns out not quite, maybe 26%. Yeah, good points.
With heart scores of 4 or 5 and rule out, and you find. But my point is if you have a heart score of 2, but your 2 is
a troponin
of 5 and ST depression, you're probably going to have the disease.
Yes,
right?
yes, for sure. And that's one of the blind spots of the heart scores.
If you enjoy the Emergency Medical Minute, please help us out by rating us on iTunes. For more free medical education, follow us on Facebook, Instagram, or Twitter. Make a donation and subscribe to our newsletter at emergencymedicalminute.com.